NTTC has embarked on to this, and we successfully completed a couple of webinars, and this is the third in the series. And today, the topic is introducing interprofessional education in the health professions curriculum. So, the moderator for the day, we have two speakers, and moderator for today's program is Dr. Jayaprakash Rajan sir, who is the head of the Department of Medical Education at the NTTC Center, JIPMER. Over to you, sir.
Thank you, Dr. Abhishek. Good evening and welcome you all to this webinar. As Dr. Abhishek said, it is organized as part of JIPMER's Golden Jubilee celebration of National Teacher Training Center, which is popularly called as NTTC, which now functions under the aegis of the Department of Medical Education. This is the third webinar in this special series. Today's topic, interprofessionalism in health profession curricula, is both timely and very pertinent in medical and health profession education. Medical and health profession education is evolving. As we all know that the field of medical education and health profession education is evolving rapidly. The 21st century is witnessing major advancement in education technology, changing healthcare needs, and growing expectations among the public. These changes are pushing all of us, not only the teacher, the policy makers, all of us, to rethink about how we teach and how our learners prepare for real world practice. In this context, interprofessionalism has emerged as a key approach to make health professions education more holistic and meaningful. Interprofessional education brings together students and teachers from different health professions to learn with each other and from each other. This strengthens teamwork, communication skills, and shared decision making skills that are considered as the essential for today's health profession, health professionals. That means for the health professionals of the 21st century. Today, we will explore this important concept with our distinguished speakers. We are privileged to have with us Dr. Siraj Ali Mohammed and Dr. Lakshmi Rajeshwaran, who will share their insights and experiences in the field of interprofessional education. I am now honored to introduce our first speaker, Dr. Siraj Ali Mohammed, who is the speaker for today. So each speaker will take around 30 to 40 minutes for their presentation. And after both the speakers complete their talk, we'll go on for taking the questions from the participants. Now, let me introduce, I'm happy to introduce Dr. Siraj Ali Mohammed, who is a professor of microbiology and head of medical education at the College of Medicine and Health Sciences, National University of Science and Technology, Oman. He chairs the Curriculum and Learning Resources Committee, leads the Destination Pedagogy Initiative, and guides the Medical Education Research Group. Holding a PhD in microbiology and a master's in health profession education with distinction, he is the founding director of the Manipal Academy of Higher Education Feimer International Fellowship and a global faculty for the International Feimer Institute. A Fulbright scholar and recipient of awards from UNESCO and Feimer, he has led over 200 faculty development programs worldwide. He has authored numerous publications and serves on several international academic and professional committees. Welcome, Dr. Siraj. So we are really looking forward for your content on the concept of interprofessional education in health professions. Over to Dr. Siraj.
Thank you, Dr. Jayaprakash Rajan, and thank you, JIPMER and faculty members, specifically Dr. Kadambari, who we did our masters together, for this invitation. It's always an honor to be at JIPMER, even though it's virtual. And today, as Dr. Zaya mentioned, we are going to deliberate on a very important strategy that is gaining prominence, especially in the field of medical education and largely in health professional education. Because it is interprofessional, we cannot claim it to be a medical education. It belongs to all health professions and even social. Sometimes it percolates into the social fabric, and hence essentially sometimes social care, and other aspects related to the delivery of healthcare come under the ambit of interprofessional education. Just confirming with the moderator that I'm can hear me right. I'm audible and my
Recording
slides
in
are
progress.
Yes, sir. Yes, sir.
Yes, yes, sir.
okay. Thank you so much. So with that, I also have with me my co-faculty, Dr. Lakshmi, who I believe will be introduced later. You can see two. I have moved to Oman. Prior to this, we started the first one of its kind, not only in India, I could say in the region, a leadership institute with the help of FEMA. We contextualized, however, for the Indian scenario, or rather, a scenario that actually takes care or looks at the health professions education in these settings. Then obviously you can see other two logos out there. One where I work right now. We have been able to do good work in the National University of Oman, trying to bring professions together, students, I must say, learners from different professions together. And recently also we did have a patient safety workshop, uh, or interprofessional patient safety workshop with medical, nursing, and pharmacy students. Um, you also see the logo of the Canadian Interprofessional Health Collaborative. The founding director, Professor John Gilbert, was our mentor in establishing this, and obviously many of these competencies we have taken, from CIHC. That is, I'm acknowledging them. And Independ is the Indian Interprofessional Education Network. Um, Many of these activities we have done under the ambit of Independ. So, with that brief introduction, let me just go ahead and state the objectives for today. Defining interprofessional education and collaborative practice, identify the core competencies. How do you actually apply these principles to curriculum design? We will also discuss the some of the strategies with curricular implementation. Dr. Lakshmi will be doing that, especially in the context of health professions education and the nursing education. And we will also appraise the significance of interprofessional collaborative practice in team building and collaborative care, which will be done by Dr. Lakshmi. Well, I want your attention towards one of the first documents that were released in that was released in this context. It was none other than World Health Organization, who actually systematically did a lot of reviews and work. And this particular publication, which was released in 2010, highlights significant events that are related to interprofessional education and collaborative care, which can be portrayed as best practices, right? This is now almost 15 years, but and if you it's still available in a free domain. If you see, there are some of those things, probably you will see that things have improved over a period of time, and by the frameworks of interprofessional education, probably you may have some questions reserved whether it is truly interprofessional or not. Having said that, it's a phenomenal piece of work that actually portrayed teamwork and collaborative care and the education required to achieve that in the context of different places or local health needs. There is an interesting diagram that they share in this, which I want to actually discuss today, which is there on the monitor right now. WHO proposes that, into a fragmented health system, if you are going to put interprofessional education, it will lead to collaborative practice ready health workforce, which obviously will lead to collaborative practice and strengthened healthcare systems or improved health outcomes. So, the reason why I have to put this before we deliberate about interprofessional education, there is a very clear reason for this, because if you look at the outcome, or if you look at the end point, basically, it is about enhancing health outcomes. So, if you are someone who is going to adopt or adapt or do something in the field of interprofessional education, you must always think twice whether it is having any bearing on health outcomes. Unfortunately, many a times people jump into many aspects of higher education. I've seen this mostly happening in health professions education, and I know that you have a good number of people belonging to that group. We may call them medical educationists or health professions educationists. It's just something is happening globally, so let's also replicate in my place, or let me all. So if you look at interprofessional education, which was very deliberately focused on enhancing the health outcomes through collaborative practice. And if your education does not translate into those enhancement of health outcomes, obviously, one must not get into this. I mean, you have many other things, many other approaches of carrying out health professions education, which we are familiar with. But unless and until it has a bearing on enhancing health outcomes, which means that it has to be patient centered, so it has to be patient centered. And if it is not, then obviously interprofessional education does not carry any weightage. So it is in this wisdom that around 6 decades, WHO systematically carried out work. You can see a number of publications and guidelines proposed by WHO to see that from a fragmented health system to a collaborative practice-ready health workforce, to ensure that collaborative practice is there, interprofessional education is poised, or it has been actually introduced in that way. So I will always recommend for people who wants to actually adopt to go back to the basics and see, to ask often, as people say in this field, where is the patient, or where are we enhancing health outcomes or the community outcome, whatever it is. So it is with this purpose, and if you consider this only with this purpose, that it really achieves the goals that it wants to achieve. Otherwise, it will be in an isolation. It's another fashion stuff, or it is my passion, whatever it is. It doesn't go beyond that. So, if you really want to go to it, I would say that crux, or at the center, is patient-centered practice, collaborative practice, teamwork, and collaborative practice-ready health workforce, and so on. Now, let's go and define interprofessional education. And even WHO actually takes it from CAPE, Center for Advancement for Interprofessional Education, located in the United Kingdom, who first proposed and said, occurs interprofessional education, or IPE, as it is often referred to as, occurs when two or more professions learn with, from, and about each other, to enable effective collaboration and improve health outcomes. All right. So what I have put in red is extremely important. So I still remember when 15 years back, when we started, baby steps towards, establishing something related to interprofessional education, and it's precisely, if you say, in 2013 and from there, and when we started on forming an institute, and we did, it was more of a strength based approach that we adopted. It was in Manipal at that point of time, and we had around 30 institutes, and trying to bring people from these institutes, the leadership basically, and trying to tell them that this is interprofessional education, we are going to plan something on this, of course, obviously with needs assessment studies and other aspects, stakeholder and related aspects. When we did, interestingly, many of the deans told us, oh, this is something that we have, and especially in allied health, dental, or medical deans, they will say, obviously, we, in many of these allied health professions, they are learning together, we put them together. But obviously, it doesn't go beyond that. It is only the first aspect, that is with. And why did we do that? We did that just because it was managing, human resources. It was more of an HR exercise rather than the real philosophy or ethos of interprofessional education. And it doesn't go beyond that. Nobody ever asked, or made any attempt to learn from each other. Even at the final years of instructions, no medical student managed to ask a nursing student who was posted in the ICU or in the emergency, wherever it is, oh, look, you've been doing like this. In your perspective, how does it work? Or in my thing, it works like this. How about yours? It never happened. And, so with, from, and about each other, to enable, there is a purpose for this. It's just not that you're putting them together. is to enable effective collaboration. We know that the science of collaboration actually ranks extremely high along with communication when it comes to enhanced health outcomes. You know, and we also know that most of the errors that happen are either because of communication issues or issues with collaboration. And if you look at directly at collaboration, issues that arise with collaboration, many of them are related even to communication. So these are all interlinked. Now, I put an acronym WIFRAB. I'm basically a microbiologist, so it looked like a vaccine for me. Okay, I've coined it WIFRAB for easy memory. WIFRAB stands for with, from, and about each other. The first step in interprofessional education, if you're planning to do, is to have at least one profession more. Now, here is another interesting thing. One would say that, look, I actually have anatomy, and maybe surgery, and then we put together the students, and then we do. So you're talking about vertical integration. You are not talking basically about interprofessional education. We also have people saying that, I did collaborate. We are all basically from the same profession, right? So then you try to bring in different disciplines from that. That is not interprofessional education. We need to clarify it, because many a times people mix these things together. You are just talking about an integration that is happening within your course, and that is not interprofessional education. You must bring at least one more profession, maybe an allied health profession, maybe nursing, maybe pharmacy, along with the medical profession. You give them a chance to learn certain topics together. And what is the idea of doing that? It has to be enabling effective collaboration and enhancing health outcomes. After some time, CAPE felt that this is not touching the practice module, so it had to be redefined. So, statement of purpose was clear then. So, what did we do? What did CAPE do? They said that occasions when members or students of two or more professions learn with, from, and about each other to improve collaboration. And then came the most important thing, and quality of care and services. So that is most important. So if you look at that, the problem with the current, in many places, I won't say everywhere, the delivery of healthcare services, they say that if you really want to know how your health system works, you must walk into the hospital as a patient, not like a consultant or, somebody who is attached. If you really want to know, you walk into the hospital and you really understand the chaos, the redundancy, the issues with safety that is there within the hospital, right? Now, this is basically one of the reasons cited even by WHO, by systematic, it's just not somebody saying like that. Evidence is there. Systematic inquiries have been done into this, and you clearly see that practicing in silos, is one of the most important reason why there are these issues related to patient safety and quality of care. So it is with this that interprofessional education was, derived, developed, designed, delivered. So it moves far beyond the classroom education into the practice aspects. And as we all often, it's a jargon that is used without we really understanding the real essence of this lifelong learning. Everyone talks about lifelong learning, right? So in practice, so it's about, so it is basically, you cannot really isolate and keep interprofessional education and collaborative practice into the theoretical domains. And many times people do that, and that is not right. For the same reasons, you will see that if there is no practice as a part of interprofessional education, it cannot really qualify as interprofessional education. It must be practice oriented, and it must percolate into the profession that I am actually into it, so that I can collaborate with other health professions. What is the whole idea is to actually enhancing collaboration is nothing but enhancing the health outcomes. So I would say that two things are important in this. One of course is the patient safety aspects, how it actually makes patient safety the core of the entire exercise. And second one is quality of care. And in countries like India, I would say it is also about economics. It's also about the financial aspects. And many a times you see, of course, with the advent of more and more foreign investors coming in insurance, we must be a little careful about these aspects, because it has to be also the financial burden that a patient has. Okay, so I would say that it is just not the patient safety and quality of care, but obviously the financial aspects of care also comes into it. What I am trying to advocate, or what I would say I'm trying to argue, is that interprofessional education and collaborative care can bring down the cost, as it has been studied in many settings. I'm very sure that if it can happen in the Indian subcontinent, it will do the same thing. It can bring down the cost, while it actually will elevate the quality of care and patient safety. It can considerably bring down the cost. That's a different argument for a different day. But what probably uh, we wanted to discuss with you at this point of time is, this is interesting because I know that many of you in this room are perhaps familiar with the new competency based framework proposed by the National Medical Commission, right? And of course, uh, we are trying our level best to see that how the skills can be, shown as competencies, and how the competency framework. There's a long way to go, but at least we have made a beginning. Now, interprofessional education was, you know, uh, designed, or was conceptualized and delivered based on very important competencies. So, as you see here, the most commonly or widely accepted competencies are teamwork, communication, values and ethics, and roles and responsibilities. I will explain this with a different slide, but what I'm trying to actually show in this slide is the learning continuum, pre-licensure through practice trajectory, to have a patient and family centered care, which is community and population oriented. That is what it envisages. So that is the continuum that we are talking about. So, in principle, it looks great, but we also have to see that how can it be enforced, or how it can be practiced. Though we have some very good examples, it needs to be contextualized in the Indian context, and it also has to be actually seen in the context of the education that you provide for your especially for your health professions, be it medicine, dentistry, nursing, pharmacy, allied health sciences, and so on. All right, that brings us to the next important aspect of the core competencies that interprofessional education will, have to, to bring in terms of its educational competencies. What is more important for us is we all have this issue, right? And medical education, especially, is suffering from these checklist issues. Okay, but in interprofessional education, one needs to move from these checklists to the competence aspects. One needs to clearly demonstrate it is just not tick the box things that happen. It has to actually really be practiced and enforced in the practice settings. And using these competencies that I'm listing here now, the students will have to be, authorized at different settings, and also to see that what are those competencies that interprofessional education brings into education or health professions education. So as you see here, what you're seeing is the revised interprofessional education competencies, which of course was based on a big study, Delphi, and then obviously based on a lot of consultations. Canadian Interprofessional Health Collaboration revisited their competencies, which I listed early, the most four important ones, and did a little bit of rearrangements. You also have the IPEC competencies from the US group, okay, relatively similar. What you see here is there is a lot of emphasis on team functioning, optimizing the team efficiency, and how do actually teams move towards shared goals. And you will also see that how team disagreements are addressed, how collaborative leadership, how shared decision making has a very important role, especially in the healthcare settings. And it also talks about, or it also considers a very important competency of role clarification. When am I relevant? When am I not that relevant, so that I can step back? Somebody else can, So these are the most important aspects that it covers in terms of, and it puts relationship focus, that's values and ethics are put at the center. So foster purposeful relationships where you can have inclusivity, equity, and other aspects. So this is the larger picture of the competency framework, the revised one. But if you look at uh, other aspects, or I'm sorry, can you see my slides?
Yeah, it is visible. Yeah, I can
Okay,
see.
Yes,
okay.
yes, yes.
So if you look at, you know, it also considers a very important philosophical shift away, we say. That is, from an exclusionary language. We often say that it is the profession specific language that actually alienates people. It could be people from other professions, it could be patients sometimes, it could be, So, interprofessional education and collaborative practice will deliberately will see that non-regulated care or service partners are also a part of it, who are active in care and service provisions. And if you look at even in the Indian context, there are many, if we can list like that, who have been left out but are active providers directly or indirectly of healthcare services. So this exclusionary language is not there. This including them, and you can also see, most importantly, including the persons receiving those care and services themselves. Though there are some aspects, and there is some momentum in terms of patient autonomy and patient movements, I think we are a country still at large finding it difficult to include patients in decision making. So this also talks about, one second, I'm sorry, this is also about including patients as partners in, just there is something okay, I think it's now clear. So it's about patient voices, right? We just concluded with one of those conferences. Where is the patient's voice in health professions education 20 years on. Strong patient education movement, patient's voice movements are there globally. And obviously interprofessional education puts patient autonomy and patient centeredness at the center. So when you're talking about the competencies that we listed, you know, if you are somebody who wants to put this into the curriculum, the most important competencies are relationship focused care. Obviously, first I defined there must be one more another profession coming along with you, learners from another profession. And these competencies of IPCPs are relationship focused care, which is nothing but values and ethics, role clarification and negotiation, and obviously it has to do some aspects with conflict and shared decision making and so on. That includes also collaborative leadership, team communication, team functioning. Now it is interesting that we just tried to map some of those activities that students, we did this with medicine. Of course, we have, that is, we have not done other professions, but when we did with medicine, we found that there are so many aspects that a person is going to leave by the time of internship, and then of course, obviously, residency becomes his own domain to focus with his own focus. But whether it is internship or the residency or day-to-day work, that demands competencies of team communication, team functioning on a day-to-day basis. If we have not inculcated them right from their undergraduate days, I believe that it is very difficult, and it becomes a tough task actually to bring in these aspects later. So when you are actually incorporating this into the curriculum with these competencies, as we have put it here, we must also consider relevance to the learner. You know, at that point, different health professions will have different levels of relevance, right? Identifying with their priority health issues. What are the priority health issues that we have? So it is basically on taking care of community needs, right? Then based on clinical practice. And obviously, as I told you, practice-based methods. I've just put interactive here, but practice-based methods are, or which practice-based learning or practice-oriented or experiential, whatever you may call as education is, form the backbone of interprofessional education. There is absolutely no theoretical. You may do one or two to to sensitize them as we are doing here, but the real interprofessional education must happen in the field. So these are the competencies. So in this introductory session, of course, in the later session talking about teams, Dr. Lakshmi will elaborate it later. But as I defined it and as I've identified the competencies, and in terms of the steps that you will follow if you want to put them into the curriculum, we did this exercise also. We have published this. You map the existing competencies. You will see that there are certain competencies already there. You can, and you will map them. And longitudinally, you got to place them. You can't say that, oh, it's only year one. What are they going to learn about it? They're not even, So with early clinic exposure, with other things that are happening in the new curriculum, we must place them across the continuum to we will keep it very optimal levels, because there are a lot of things our students have to do, but these things are more practice oriented. And of course you may have to build in some form of assessment if you really want them to take if they really have to be serious about these things. Now, collaborative competencies into the existing courses. And you will see that some of these courses that we have, these competencies gel very well with that. But that doesn't mean that there are courses in which you cannot put that. Every course you can. It requires people to sit around a table and discuss. But most importantly, what is required will be what you're doing right now is to sensitize people. It is to talk about these things and make our people, uh, skillful enough. And for that, faculty development, comprehensive faculty development. And I don't have to advise something, to people from JIPMER who have always pioneered faculty development in the country, right? Most importantly, employing diverse instructional methods. This is talked everywhere, but it's most importantly in interprofessional education aspects. If you want to put that, you will have to use different types of and approaches. And as it is for any curriculum, you got this general scheme of how you get into this, and you got to implement assessment schemes that are valid and reliable, and most importantly, evaluate to establish associations, because people are really interested. You have evidence. Does it work? Of course we have enough systematic reviews and evidence gathered, but in our own context, in our own setting, in our own regions, in our own country, we will have to create our own evidence and show that that these work. You may call it return of investment or whatever it is, in terms of how this is working. So this is in a nutshell. And I will not go into any details of it, but there are very strong theories that we generally use in the educational scenarios, which support interprofessional education. It could be the adult learning theories, social contact theories, social learning theories, social capital theories, social identity theories, and organizational learning theories. That have form a very strong basis of supporting interprofessional learning. So you don't have to reinvent the wheel again. These are all embedded. But what is most important is for us to realize that you cannot get into mastery, immediately, or so this also follows the logical progression of including them, I mean learners, and first step is how they get exposed to it. A variety of uh, approaches that sensitize them or introduces them to teamwork, to collaborative leadership. That is the first step. Then is where you have especially in clinical settings, immersion, where you are along with other health professions, learners from other health professions. You also are actually going to develop some skills related to this type of collaborative care, and it's only mastery comes at the later level of it. But interestingly, you can also see to your left, from a uni-professional identity, okay, uh, through interprofessional and other learning aspects. I would say that this is an old terminology, uh, dual identity development, but today we talk about interprofessional identity. It is not just the dual identity, because we must consider it as interprofessional identity. So the interprofessional socialization framework that puts them into contact with other professions. You exchange knowledge and skills with others. So, as a doctor, the student will obviously have a uni-professional identity, which he or she must have. So that doesn't mean that this is one debate that often happens in this scenario. Are they losing their own identity? Am I losing my? No, you are not. You are developing another identity, that is an interprofessional identity. So both are important in the context of the profession, but it is more important that we develop these interprofessional identities for the sake of patients we care, right? So I would again try to bring in the same aspects of quality of care and patient safety, and it is in this context we talk about this. So at different levels you got to arrange it. I already mentioned about it. Experiential, reflective, and situated learning forms the backbone of interprofessional learning experiences. Just touch on what are the methods and approaches. To begin with, often You could start with generic team building exercises. You don't even have to talk about healthcare at this point of time. It is most important to develop people who function well within the teams. And then there are people who give shared instruction. You give a core content, say diabetes mellitus, and there is shared instruction. But this is also not truly interprofessional. Then comes a shared content, but with a deliberate interprofessional focus. Trauma care, geriatrics, the focus is purely interprofessional. Now, how do we put this? Sometimes people find it difficult in a very, structured curriculum. So people use different methods for doing it. Sometimes there are intermittent discussions throughout the curriculum. It could be seminars, symposia. You will see that in many medical schools, not India, I'm talking about, there is a separate course at a particular point which focuses on interprofessional and collaborative practice. You will see that there are also schools where there is an individual clinical placement. They have to go through that. It could be during the final sem, or it could be the final years, or it could be even during internships. An individual clinical placement where IPP is a mandatory requirement. Now, there are also schools which keeps IP as an elective program, but it is important for them to go and have this elective done. It could be, as I told you, could be in trauma care, could be in, it could be in elderly care. I mean, geriatrics. It could be, so these are different modalities that people use to introduce this. But as I conclude, I want to tell you that it is not many a times it is not these formal environments that actually brings in the interprofessional education. There are a lot of informal, or sometimes known as non-formal, serendipitous encounters. Could be outside the ward, or somebody actually as they are in the library, or could be even in the canteen. There are exchanges that happen among different professions and learners from different professions, and we all have experienced this. And it is said that these serendipitous, these informal gatherings, or these informal interactions must not be ignored. Many a times they provide enough fuel for the interprofessional learning that actually percolates into practice. Just a word while choosing the tool for interprofessional assessment. We need to look at which professions are to be assessed and what are the competencies going to be assessed. And now there comes a lot of debates and questions. Which professions can one health professions alone assess, or it has to be multiple? We are relatively in a field, this is in the field of assessment of IP is still evolving, and obviously we got to talk about format and timings of assessments, formative, summative, and other aspects that capture reflective learning. Then there is a very important question. You talk about team-based cultures, you talk about team-based learning. So are the assessments individual, team-based, or are they mixed? So there are a number of aspects related to impact of assessment on learning, which uh, uh, which is still a very naive field, and obviously there needs to be a lot of faculty development to be done for the assessors. Uh, there are a number of assessment methodologies, listed, and that's the reference. You can see that many of those are team-based, and that does not actually keep out the individual reflective journaling or workplace-based, where you're going to observe. But you also see a good element of peer assessment, team-based critics, and team-based OSCEs, and a number of other methods that have been listed here. Due to time constraints, I will not go into the details of it, but just to sensitize you that interprofessional assessments often will need to be assessed as a team. And obviously, the 360-degree assessment that many of you are familiar is a very important aspect. But having said that, you will see that assessment of interprofessionalism is like, it always sits in the middle of that very dangerous triangle, the Bermuda Triangle. The three aspects that we often have to address will be meeting professional standards, meeting patient expectations, and so if you look at professional standards, training schools have to meet professional standards. Till date, we don't have an international agreement, or we don't have a proper consensus concerning interprofessionality. And look at the patient expectations. Everyone would like to have seen by somebody who is qualified. but they have very little say in who qualifies. So that is patient expectations. And obviously, faculty development that we talked about. So faculty must develop assessments to meet the professional demands, right? So uh, it boils down to having very defensible, robust measurement tools to prove who is worthy of progression. So that is why we often say that it sits in the middle of tension triangle, though most of the aspects related to learning, we have been able to really look at that, and we have been able to evaluate systematically and say that it works. The assessment aspect still is in the process of evolvement, and obviously there is a lot of things happening in this field related to interprofessional assessment. So finally, uh, as Aristotle says, for the things we have to learn before we learn by doing them. Obviously, you can't wait for it. You got to do it and then learn. So it is all about from theory to practice, and it's about the FDPs or faculty development programs that must happen systematically. We must tell people what are the competencies and frameworks. These are not discipline specific or profession specific competencies. These are competencies related to communication, teamwork, collaborative care. So people also must be taught how do you design, courses in this context, instructional design. How do you actually facilitate such sessions? Then, how do you actually take care of interpersonal collaboration and leadership skills? And finally, and most importantly, for people who are attending this, I know there is also an element of interprofessional scholarship embedded into it. How do you actually do that research? How do you provide evidences? And how do you evaluate? So, still, it is lacking, especially if you look at the Indian context. We have very minimal evidence in all these things. And I would say that, we must take this. People who we are as bunch of smart people, and we must be able to evolve our own mechanisms when it comes to these domains. But let me tell you, this is not a peripheral add-on. This is not something that we are doing on a Saturday afternoon because it is raining or because we don't have something to do. It has to be embedded into the curriculum, right? People often ask us, is this as important as my profession specific experience? Now, if your profession has to enhance health outcomes, sometimes it becomes as important as your profession specific experience, because you and me work for enhancing the health outcomes. Now, we will see that one challenge that we face is there is, equity of learning opportunities are lacking. And we also have to discuss, this discussion we talked about from checklist to competence. Now, it is also time to discuss about competence versus capability. Are you actually making graduates who are capable enough to work in those systems that can actually provide collaborative care? Faculty development, faculty development, faculty development, because that becomes the most important aspect to be addressed. And also, instead of viewing only as a tool for accountability, how do we use assessment as a method for improvement and learning? And this echoes in many of the educational fora, just not interprofessional education. And you must understand that you cannot really rush into this. It takes time. And this is perhaps a framework where your interpersonal relationships do matter. It's not that I cannot say that, I'm good in this, my own subject, I am skillful enough, I don't care. No, it doesn't work with interpersonal education and collaborative practice. We teach our students and we walk the talk. Relationships do matter. When we were doing this, we were surprised to see that in our own settings, hospitals, and clinical care facilities, there were already pockets of interpersonal education and practice existing. They don't call it, they don't know that it is, but it is there. When you go there, and our effort must be to go identify these and fan this, or you can actually use these as prototypes. And always starting small helps. I'm talking about people who want to really put this into their curriculum, and slowly mutual and multiple reinforcement will see that it works. And you must also consider the sustainability factors, and as mentioned in any other settings, resistance to change is often there, right? And you will have to consider those aspects. And I end with a cartoon that I have borrowed from, again, Canadian Interprofessional Health Collaborative. As the public walks through this and they see that number of these health institutions or health professions institutions, and it is just the doubt of the layman, how can they work together if they don't learn together? I think there are certain aspects, it's a must that we provide circumstances, environment for people to learn together. Thank you so much. I will take your questions after Dr. Lakshmi has finished her presentation. Moderator, is that fine, or you want me to take questions now?
Yes. We can take the questions after both the speakers finish their thing. Okay, presentation.
Thank you
So
so
for
much.
now, we will hold on here. Thank you, Dr. Siraj, for your lucid presentation. It is such a complex topic. You have made it in a simple manner so that it is really okay, understandable for all of us. One more important thing is that you have really enlightened our mind with regard to this new concept. I would say that now interprofessional education is becoming an education movement, not just a concept. It has become an education movement throughout the world. So I think this is the right time that you have ignited our minds. So here we'll stop for now. And I request all the participants to note down their questions. So once the second speaker finish a talk, I think both of them will together take the questions from you. Thank you, Dr. Siraj. Now, regarding, over to Dr. Lakshmi Rajeshwaran. Let me introduce the next speaker, Dr. Lakshmi Rajeshwaran. Dr. Lakshmi Rajeshwaran is an associate professor in the Department of Nursing and Midwifery, College of Medicine and Health Sciences, University of Rwanda. She is an accomplished nursing academic and clinician with extensive international experience across India, Kenya, Botswana, New Zealand, Rwanda, and the USA. She has taught undergraduate and postgraduate nursing, especially nephrology, critical care, and health assessment, and has mentored master's and PhD students. She has led curriculum development, community outreach programs, international internship collaborations, and several funded research projects. She has contributed significantly to renal care education, research capacity building, and nursing professional development. She is also a certified BLS instructor and recipient of Botswana National Award for Teaching Excellence. Welcome, Dr. Lakshmi Rajeshwaran, and over to Dr. Lakshmi Rajeshwaran.
Thank you, Doctor. It has been a big pleasure and honor for me to do this presentation in front of esteemed academicians and also clinicians and my fellow colleagues. And like the moderator introduced me, I have been in Africa for more than 35 years. I did my undergraduate in India, and then later I moved to Kenya and then Botswana and South Africa, and now I am in Rwanda. So on this note, I also want to express my sincere thanks to Dr. Kadambari, who gave me this opportunity to do this presentation, and also Dr. Siraj, whom I met during this collaboration. So thank you so much. So the topic which are you able to hear me, please?
We can hear you, ma'am. Ma'am, we can hear
Yes, ma'am,
you.
you are audible.
And what about the slide?
Slides are visible.
Oh,
if we can put it in
so much.
slideshow.
Yeah, I'm putting on the slideshow. So the topic which I was given is how does the interprofessional learning contribute to better teams in healthcare settings? So initially, this topic is quite new to me, although like Dr. Siraj said, we have been doing this interprofessional learning in informal way in many aspects. But when I was reading and researching a lot of articles, and then it is taking a momentum in many parts of the world, and also already it has been established in the US and also UK and in some European countries. And I read then even in Southeast Asian countries like Thailand, Taiwan, Qatar, and even in India, it has been implemented. I'm not sure about it, about the India, but I was reading the literature about it. So now my presentation is going to be about the definitions of interprofessional education, which has been touched by Dr. Siraj already, and interprofessional learning, and some principles of IPE, that is the interprofessional education, and IPC, and advantages and disadvantages of interprofessional learning, which everybody should know before they embark on this educational model, and also some barriers and enablers and role of healthcare professionals, particularly on nurses. Since I have a nursing background, that let me also focus some aspects on nurses, how they team for that profession. And everybody knows this one of Institute of Medicine report, which was published in 1999. And the report stated that the highest quality of patient's care can be given only all the team members work as a team and also communicate effectively, which will ultimately enhance the patient's care. So this report came after, it has been identified that most of the medicational errors caused an alarming news to the population, and this has been the wake-up call for many healthcare professionals. So basically, it says, like Dr. Siraj said, our focus should be on patient-centered care, not, going around and, not focusing on the patient. And also, we should work as an interdisciplinary professional. I mean, in an appropriate way, I should say that. And then whatever we are doing, it should be based on the evidence-based practice, and also the guidelines should be applied. And ultimately, we need to strive for the quality improvement. And it also mentioned that you utilize the informatics and the advancement of technology. So the WHO, it defines that interprofessional education is settings where two or more professionals learn about collaboration and improve health outcomes. That was, defined in 2010. And recently, the Global Health Force, also emphasized that changing the demographic profile of the diseases and also emerging new pandemics and new diseases, aged population, it really warrants all the healthcare professionals should work as a team for the better outcomes, health outcomes. And IPE, Interprofessional Education, and IPCP were introduced more than 40 years of age as means to address the complex health needs of the communities through collaboration between the professionals across all health areas of health. See, this I just want to mention one example here. When I was a new graduate working in Chennai, in dialysis unit, and those days the nephrologist would call all of us and participate in the interprofessional. It cannot be in a formal way of interprofessional rounds, but he will involve us, everyone, including nurses, dialysis technicians, and he will, it was a case-based approach, and we were learning so much from those kind of interaction. So it has been in the practice, but probably the momentum has come now to formalize and introduce the interprofessional education, since the many changes are taking place in our educational system. Next slide. Oops. Are you seeing my slide now?
Yes, ma'am. Yes, ma'am.
Okay, there was some, I think, communication gap. Gap. So the definition, some of the definitions which we know already, the interprofessional practice is the collaboration of the practice which is happening in the clinical settings. And learning, of course, it can happen in the classroom or in the simulation lab or in the clinical setting. And also this interprofessional education is a special educational approach designed to prepare the healthcare professionals for collaborative practice to avoid working in social isolation. Because many a times I noticed that we don't work as a team, because doctors will come and write the notes and then he will go, and the nurse will come and take the read the notes, and they try to implement the patient's care. But the interprofessional education will definitely enhance the collaborative practice, and it will also help the learners to understand how to work as a better team members. This is really a data. So these definitions, team and team learning, we all know. I don't want to brood much on that. And this one actually, it's a small difference where we are expected to know what is the meaning of the multidisciplinary and also the interdisciplinary and interprofessional. If you look at the interdisciplinary, All of them are focusing on the patient, but according to this author, she says that there is a little interaction between the other team members. And similarly, even the multi-professionals, they rarely share the knowledge and skills among the team members. Whereas if you say interprofessional, all the team members are interconnected and their main focus is on the patient care. So they share, and then they really make decisions based on the patient's conditions, and all the team members are involved, which will help everyone to bring out the best patient outcome. So interprofessional learning has been defined already, and then it may develop during interprofessional education, during interaction in educational settings or clinical settings, where students from different professions learn about from and with each other. So IPL and IPE can be used interchangeably. But for IPL, for interprofessional learning to happen, first of all, we need to have an interprofessional educational curriculum model which can help us to develop proper modules and also develop the learning, teaching and learning strategies. And it also helps to develop skills in for interprofessional collaborative practice. I think there is some network issue from our side. So certain processes are required for effective IPL. It's like a more theoretical aspect. But when I was reading the research articles or literature, then they say this one is very, very important, and each learner should have this kind of processes for them to participate in a team learning. The learner should have a cognitive process whereby the person will be able to apply, synthesize, and also make a congruent decision regarding the patient's care based on the team agreement. And the next process is reflective process, which also helps the person to sit and think what went wrong and what has happened and what inferences can be made out of this educational activity, and how they can improve the patient care. And it does not happen without using the problem solving approach and also critical thinking. And the entire learning is based on the experience, and it is happening in the social environment or social learning, because they are interacting with many students or the learners from the different disciplines, and they have to learn, ultimately how to develop and mutual trust and relationship, and that will help them to have an effective interprofessional learning. Oops. Principles of interprofessional learning, I think this has been touched by Dr. Siraj, some of them. Each person has to have a mutual respect and trust. Without that, the learning cannot take place in an appropriate way. And interprofessional communication, this is, I want to emphasize more on this, because many a times the learners are the other professionals, they don't know how to communicate with each other, and that can hamper or hinder the interprofessional learning. And they have to really develop some kind of tools for the learning how to communicate among each other. And the roles and responsibilities are to be delineated very clearly, and they have to have shared values. Each one should come, they cannot come up with the different values and belief system, and it has to be again from the team and teamwork. So team and teamwork, which was the focus of our topic today. So how this helps them to to be a better team based on the mutual respect and trust, and also based on their values and attitude, and what kind of knowledge they are coming with already from their profession. So advantages of the interprofessional learning for better teams. I have been classifying this as a personal growth, and also how it can improve the system-wise, outcome. So first of all, each individual can learn how to collaborate and learn from each other, and also it helps them to build confidence and create a professional identity and role clarity, because when they work as a team and each one, if they know their role clearly, and they will know how to function in a bigger team to bring the better outcome of the patient. And it also improves the self-esteem and self-efficacy of an individual. At certain aspects, like other qualities like equality and respect and empathy and compassion, this one, nowadays it's missing among our healthcare professionals. This has been also touched by the speaker who was speaking 2 weeks ago, Dr. Gitanjali. She mentioned these soft skills are missing among our healthcare professional nowadays. So when they work as a team, or when you develop a curriculum for the interprofessional learning, how to be empathetic and compassion and caring, those kind of concepts should be inculcated from the beginning itself, so that the professionals can talk among each other and also provide comprehensive holistic care. And it also give the biggest advantage of how to support each other and also supervise each other for a better team outcome. So then other aspects, of course, effective communication and conflict management. It helps how to manage the conflict, peer learning. That has been touched by the Dr. Siraj. And here I want to focus more on this shared mental models, because when they work as a team, learning helps them to develop different concept models. For example, prevention of pressure sores and also prevention of fall. Each one can have an idea, and each discipline can participate in developing the concept models. That comes from the team learning. And also reflection and feedback. When they reflect and give feedback with each other, that will help for the better team output. So this this study was conducted in Hong Kong, and they found in the research that these are the outcome of the or contributions of the by the interprofessional learning. And some of the benefits, of course, it helped to, this study was conducted in Qatar, and it helps to reduce the medical error, and it also improved the patient's satisfaction, and ultimately to let the quality of care and enhance contentment from the staff and also from the patient. And it decreased the burnout of the staff, and it also help to have a better coordinated care. And many a times it also reduce the readmission or recidivism of the patient coming to the hospital again and again, because the team learning helped and it has been applied to the practice. Some of the positive and negative impact of interprofessional learning on team. Positives have been highlighted, particularly it helps the individual to develop critical thinking and clinical reasoning and better clinical judgment, and it improved the patient's care. But negativity is, when you focus on that, if the team members are not aligned together in the same level of knowledge or from the discipline, and the feeling, each learner can feel intimidated by the other team members. That has been, highlighted as an intimidation. And power imbalance and hierarchy. This is still existing in our system, because I have been observing both in India and also in some other parts of the world where I have been working, this concept of doctor lead and nurse follow, and nurses carrying the trays and other things. I'm not saying that it's wrong, but at least those imbalances or the power hierarchy should be mitigated for a better interprofessional learning outcome. Otherwise, if we come up with that kind of mentality, then it's going to create a huge gap between the team members, and it may not enhance the team learning. And incentive to team members, if somebody feels superior than the other team member and try to ridicule the other one, then that can also hinder the professional learning. And negative personal identity and negative emotions. So these are all some negative aspects of the IPL or on team members. So when we consider to develop model, or when we want to implement the interprofessional education, we need to look into the different aspects of positive points, and also what kind of negativity can happen, and how we have to be mitigate those kind of negativity by reducing those imbalances. This one, all the points have been touched except the IPL, interprofessional learning, break down the professional silos. This point has been touched by Dr. Siraj. Professional silos is the point where we all work in isolation. No one communicate among each other, and then they come and go as an individual team member. So when we implement or when we learn in the interprofessional learning environment, it also reduces the professional silos. And some of the barriers which has been highlighted from the research articles, individual level barriers. If there is a lack of role clarity and appreciation, the individual can get some kind of, complex, and they may not participate, and that can be a barrier for the learning. And attitudes and prejudice and personality conflicts. So these are all simple explanation. And team level barriers, leadership ambiguity. That is, if the leader is not clear with the vision, what is the goal to be achieved when they are working as an team? If he is not clear about for the achievements, then that can be a barrier. Communication issues and also team structure issues. They should know, each one should know when they are in that team, what is the expectations during the learning process. That can be helpful for them to learn in a better environment. So some of the barriers here, of course, it's a bit small. Uh, that is a hierarchies we talked, and also stereotypical behavior, because we have this mindset. So registered nurse or the junior doctor only will do certain things, and then that kind of stereotypical behavior, again, it can be another barrier. And the traditional education, this has been touched by Dr. Siraj again. And also the faculty buy-in. If the faculty members are educators, if they are not willing to address or accept the change, if they show some resistance, then this can be another barrier. And also the lack of understanding of interprofessional learning. Everyone should be on the same level of understanding. For that, sensitization programs are needed from the beginning when they want to practice. This is also very important, because each profession has the scope of practice. If it's something out of scope of practice, then the person, nurse especially, I'm just quoting a nurse, they may say that, it's not within our scope of practice and I don't want to do this. That can again be a barrier. So everyone should be knowing what is their limits and how they can work as a team. I was reading another study on this note. Then when they were learning as a team, the nurse was wearing a lens of doctor, and doctors were learning a lens of pharmacist, and they were working as a team and see how they can learn from each other, and that benefited him to know each other's role as a team. So we can also follow that, but it should be within their scope of practice. And healthcare system, of course, we all know the shortage of staff. It's universal. Everywhere there is a shortage of staff, and high burden of clientele rate. and also increased workload. This is also very obviously seen in many settings because the nurse patient ratio or doctor patient ratio, particularly in developing countries, it's more than recommendations. So they are not able to participate in learning. They just come and work and go, and they are not interested in learning a new aspects also. And power dynamics, again, it's a hierarchy system as point. And management and leadership, poor leadership can be a big barrier if the leader of the team or if the organization is not motivated in implementing the IPE, and that can be a barrier, and lack of training and continuous professional development. So nowadays, the one attraction for, here when we say that we are offering some points as a continuous professional development, at least you can expect some participants to come and participate in our seminars or, webinar. Otherwise, that is, if there is no any other incentive, they are not willing to participate. So we need to devise certain kind of strategies even before we start this program, and then see how best we can organize as a team and then teach the learners in the different environment. So the next slide, some of the enablers. When we talked about the barriers, obviously there we need to focus on the enablers also. Some enablers are faculty education, that has been addressed already, and linking theory and practice. We teach something in the classroom as an educators, and when the students or the learners go to clinical setting, they see completely different things, and they ask us what is happening, because there is a huge gap between whatever we are learning in the classroom and we are not able to apply that. So that gap has to be addressed from the beginning. That needs a lot of collaboration between the academicians and the clinicians, so that this theory practice gap is addressed adequately from the beginning. And also addressing the issues of scope of practice and leadership and financing, which I talked about it in the earlier slide. And other things are use of technology. Of course, everybody should be on the advancement, and they should know what's happening in the technology wise. Now this AI and other things are coming into the practice, and we should to be getting up to date with a lot of developments. And also whatever we teach should be based on the guidelines, evidence based guidelines. And mock training also will help for the one of the enabler for the interprofessional learning as a team. Actually, for example, when you teach about the basic life support, advanced cardiac life support, and other programs, then each one will know what to do and exactly when to do certain things, and then that training helps them to work as a better team. And sharing of real life experiences, this is very, very valuable, because now the real experiences from the seniors can help them to learn. And again, as is a part of mentoring, they can learn it in a proper way. Although some of the things may not be applicable for them in the nowadays environment, but still they can take the main points, how those particular issues have been sorted it out, and that can be a good experience for the youngsters. And ethical principles, all the teaching and learning method should be based on the ethical principles. Without that, it is difficult to implement, and we need to be very transparent and follow the basic ethical principles when we are developing the curriculum or any new model. Some of the enablers, again, I don't want to dwell on this much because it has been touched already. This study has been done in South Africa, and this study has been identified that there is when we teach the IPL, or when we do the IPL, that mixing the skills, expertise, and competencies can also help for be a good enabler for the better team learning. And regular professional interprofessional meeting, that's also very important, because when we have an meeting, I'm not sure how much it's being implemented in your setup or in other places. I went to the US for a collaborative process, and that was a good learning experience for me, because in the UPenn, what they do, they sit as a team, different disciplines, and weekly once they meet and they discuss about the patient. And we also participated in the team rounds, where the team went and they were observing the spot medication errors. So it was a combination of nurses, doctors, pharmacists. Everyone went and checked the records, and then they identified how much of medication errors or incident report has been reported. So that was a very, very highlighting experience for me when I went for a collaboration. So although I didn't know about it was interprofessional learning, but that interprofessional meeting helped us to learn it in a better environment. And partnership and collaborative research, this one also I want to emphasize more on that, because when we do research, we wanted to just team up with our own doctors or nurses, and there is not any collaboration between the other disciplines. So I really request our, what do you call, listeners, please engage in the collaborative research, so that others also come on board, and then they need to really contribute to those research skills. And so that if you want to, develop some evidence-based guidelines, it can be across all the disciplines, and can be implemented in the practice. So these are all the some things which I wanted to highlight on the team and team learning advantages, barriers, and some enablers. Now, moving on to the role of nurses, how they can be a better team member when they want to be in an interprofessional learning environment, and when if they are wishing to upgrade the profession. First of all the nurses have to uphold their core competencies. What's happening in their daily practice, that needs to be upgraded regardless of their area of work. In special units, for example, if they are working in critical care unit, certain competencies are expected. Besides skills, and also some of the soft skills, like how to communicate, how to be more empathetic, those things has to be also practiced on daily basis, and it has to be updated. And interprofessional communication, how to communicate among each other team members, team and teamwork, we talked about it, and that has to be emphasized. And also the collaborative culture, advocating for resources, this is also very important, because while I was in Botswana, the health minister was a nurse, and then she moved to some international organization. So nurses should come forward to participate in the policies development, and they should play a major role in engaging themselves in a higher level at the ministerial level, so that they can advocate for the resources rather than complaining there is a shortage, this and that. We need to really be a leader and make the nursing profession. Most of the baby boomers have gone, and now we are dealing with Gen Z and Alpha. Or, I don't know what, the generations are coming in. So those younger generations should learn from the nurses or the doctors who were in the clinical area. So it's better we function as a good role model, and also mentor them on the essential skills of caring aspects, self-reflection, and also stay informed with the current development, whatever is happening in the profession. So I don't want to generalize here, but this is common for all the nurses wherever you are working, so that we, make progress in the nursing profession, and also for the clinicians. So the way forward for the better teamwork, most of the points have been touched. So one of the aspect, like Dr. Siraj mentioned, rather than before implementing the interprofessional education, we need to go through these accreditation standards through the different stakeholders and also professional bodies, and we need to make some common consensus when we are embarking on implementing the interprofessional learning or interprofessional curriculum. So otherwise, most of the points have been touched, and regulations to support interprofessional learning is also very important. There should be any clear regulations, rules and regulations by the governing body. And some of the strategies I have been mentioning here. So here also we talked about the shared vision and goals and mutual respect and other points. But main aspect is I just highlighted here debriefing sessions and non-punitive culture. This is also very important because when you work as a team, if some team members uh, done something, then it's better to have a debriefing fitted. So they acting also participate in the team learning. These strategies may work better in clinical practice and even in the classroom settings. And also non-punitive culture. Many at times, immediately when somebody does some mistake, we have a tendency to tell them, no, you will lose the job, or you will be changed from one hospital to another hospital, or you should write an incident report. Of course, writing incident report is good, but it has to be in a non-threatening environment. So basically what I'm trying to say, for us to have a better teamwork, be it in the clinical practice or in the classroom, we have to have certain kind of mechanism where this culture is being practiced so that the learner is not threatened, or the person who is participating in the is also better way to go about it. And then the role of nurses in AI, I think nowadays the hot topic of discussion is artificial intelligence, and it's going on everywhere. It's not only for nurses, even for other clinicians and other healthcare professionals. But I just focus on the nursing education. So nursing education is to ensure future nurses or even the current nurses, not only the future nurses, are expected to be AI literate, and they have to be equipped with technology development and integrating AI concepts, especially when you develop a new curriculum, and then data interpretation and informatics into the curricula is also very important. But using AI enhanced simulations and virtual reality to create realistic training scenarios also can enhance or improve the learning in the team or in the clinical practice. But one thing what we have to remember, the downsides of using the AI, the previous presenter 2 weeks ago, Dr. Gitanjali mentioned that not in aspect of AI, but caring aspect. When you introduce a technology or any AI thing, it is not going to replace the nursing, caring, empathy, or any emotions or touch. Touch is also very important thing. So that will be should be taken care when we teach about the AI aspect in the classroom, and also data breaching and privacy. And again, some of the algorithms which are created by the AI can mislead our healthcare professionals because the data is fed by the human being, and if there is some kind of misinterpretation, the nurses can, or the doctors can do something inappropriate way. So we have to be cognizant of the disadvantages of using AI, but AI can be augmented in our educational system, but it cannot replace the doctors or nurses. One point which we need to be bear in mind when we include those AI concepts in our curriculum. And the other thing also, nurses and doctors can develop an ethical principles and guidelines for us how to protect the data and how to protect the patient from the technological advancement. Maybe it's taking place already, but we have to be, taking ourselves forward and sit in front of the policy making and make some changes in the profession. So this model, Dr. Siraj mentioned about it. Of course, he was telling that learning is a continuum, that we all know from the beginning. And this model has been mentioned by Institute of Medicine in 2015, and they say that interprofessional learning should start from the educational foundation education itself. In some universities, it is a pre-graduate or it's a requirement which is being done in the beginning itself, and then it's progressing to graduate, and it's continuing until we finish our profession, because learning does not stop in one go. So we need to bear in mind that learning is always, learning good things is always good, and our brain gets sharpened also. So I'm not going to focus more on learning outcomes and healthcare system outcomes, which you have seen already. But when we develop any curriculum model, or when we want to implement the IPE, some of the confounding factors should be bear in mind. One is professional culture, because if the leader is not aware of the changes, and if he is having an ambiguity or ambiguous feelings, then that can also affect be a confounding factor. And institutional culture also, again, the team should be equipped with necessary knowledge and skills how to conduct an interprofessional learning, and everybody should be trained on that and sensitized on that. And also they have to be having a, with the assessment, they should know how to kind of gender inequality. This is also existing in our system sometimes. I don't want to sideline the ladies, but gender inequality can also assessment. So that needs to be also eliminated. And cultural contextualization is very important. When you develop any module, and you have to be culturally, it has to be culturally contextualized, and it has to be tested and validated, rather than jumping into introducing into the new interprofessional education module. I mean, learning or education, and we need to be cognizant of all and to eliminate all those as before about those in professional education. So this is the one and presentation. So in the current LEL and IPE will eliminate the segmented education between the healthcare professionals. Like I told in the introduction, there should be a collaborative practice to improve the healthcare system and also provide comprehensive approach for IP.
You are unmuted. Muted, man. Please unmute.
Are you able to listen, hear to me now?
Ah, yes, ma'am. Yes.
Okay, these are some of the references which I took for preparing.
Your slides are no more visible, ma'am. Your slides are no more visible, ma'am.
From chat oh, hello.
Ma'am, your
Hello.
slides are no more visible.
Oh, okay. But I'm almost done with the presentation.
Okay.
And
Okay.
I just gave the references. And thank you for listening. And I appreciate your time. And so some of the points may be replicated by me based on Dr. Siraj's presentation, but it is a learning experience, and I hope it will benefit the audiences. And if you want to implement the IPE, best wishes and good luck to your institution. Thank you so much.
Thank you, ma'am. Thank you, ma'am. So that was a wonderful presentation. If Dr. Siraj's talk is like a spark, your presentation served as a thread that helped us to connect Dr. Siraj's talk. Both the talk combined together was really effective. That really helped us to understand the concept of interprofessional education, or I can say interprofessional learning. Both of you beautifully explained the concept, the underlying principles, the competencies that need to be developed among the learners, as well as the barriers or the challenges that one can face while implementing it, while formally incorporating it into the existing curriculum. And you also shared some of your experience, real workplace experience, what you have undergone, that really helped us to connect the information with the concept. Right, ma'am. So with this, I think we can move on to the question answer session. Now I invite all the participants to post their questions. So before you post your question, please mention to whom you are asking the question. Is it a common question for both the speakers or specific to one speaker? Or if you find, you can even post the question in the chat box also. So in the meantime, Dr. Siraj, what is your opinion regarding the implementation? Do you think that is it easy to implement in a country like India? Because where though the medical profession is an interdependent environment where we are supposed to work in interdependent environment, but most of the time it is not so, isn't it? People work in isolation, and we are used to that type of culture. So what is your take on this?
Thank you for that question. I can see a similar question from Nivedita. How would you actually convince your leaders to adopt? So I think there are two important issues in this. One, obviously, you are looking at, uh, you know, if you want to place interprofessional learning or interprofessional education into your system, in a country like India, that was a question. How do we actually? But I don't see anything, going against the implementation aspects. If you look at the current NMC guidelines, we counted actually, I don't remember the exact number. There are a number of times it is very clearly said teamwork and collaboration, teamwork and collaboration. Now, it's not difficult if people come together, especially it has to come from the clinical side, to actually bring the interprofessional education aspects into the teamwork, especially, let's say, for example, we are talking about patient safety. Now, when you're talking about patient safety, obviously there are issues related to medication safety. There are issues that are related to quality assurance in terms of, how do we learn from errors and other aspects. Now, the best way actually to administer this, we all know that it has to be, at least with other people or nursing profession or pharmacy people who are around. So, it is while it is possible to do, again it is a mindset that plays a very important role in these things. And you have seen that if it has to work, it has to come from above. So if you look at the accreditation or regulation or regulatory authorities throughout the world, you start from WFME to down below, if you everywhere there is a mandated requirement where students, especially in health professions, must come together, to solve some of these patient problems together. So that is one aspect as far as the frameworks are concerned. The second one is the real implementation, and that is not that easy. I would admit that, especially starting from scheduling to actually, you got to meet. Early it was only one department. Now one dean has to meet the other dean, or at least communicate with the other dean to say that when are you going to release your people. So we have been through these things, and if you have a good leadership and a good understanding among all these people, it becomes easy. Otherwise, I do admit that, it is not easy as scheduling a lecture or a PBL or a clinical session. IPA sessions will have to be pretty much decided much earlier, like we have an academic schedule running, and then decide. To begin with, I think we must identify some common areas, and we should see that it happens as, it could be even as workshops, it could be even as some postings that are related to it. We cannot suddenly jump, and nowhere you hear about a completely transformed interprofessional education curricula. Like many other approaches, interprofessional learning must be used as an approach judiciously and to fit the resources of the institute, but to address collaborative care and issues like patient safety. I hope
Thank you.
I.
Right. And there is one more. There is another question. Dr. Kadambari wants to speak. Dr. Kavita, please unmute Dr. Kadambari. Miss Kavita, are you there?
Thank you.
Okay.
Thank you, Dr. Jep. That was a very enlightening session by Dr. Siraj and Dr. Lakshmi, and there were many, many learning points. Thank you both very much, and I think it has given a lot of food for thought and how to do this. I just have one small comment. Way back, Dr. Lakshmi, when we are probably in the similar age group, when we were studying MBBS, we used to have common classes, particularly in anatomy and physiology, along with the say medical lab technology students. And in those days, we didn't have nursing yet started in JIPMER, but we used to have classes with the ML students, and particularly in the basic science. And that when and those friendships that we formed with those, they went on later to become technicians, but that relationship that we established with them as we studied together, I think that held on for a very long time. And even with the nurses, as we trained as interns, I remember that my labor room posting, I learned how to do a normal delivery from a nurse rather than from a resident or a consultant in gynecology. So this has been going on at an informal level and probably was very effective. We did have respect for each other. We knew how to work with each other. When consultants went on rounds in surgery, for example, the nurse used to accompany the head nurse of the ward. So somewhere along the way, I think these practices have dropped out, and therefore we are now coming to this formal thing about interprofessional education. And as Dr. Siraj mentioned, there are a lot of challenges. I think both of them have highlighted the major challenges of the hierarchy and the ego issues and things. So I think it's a big challenge, but it's very essential. And thank you both very much for this very enlightening session. Thanks.
You're welcome.
Sir,
There is a question from Dr. Sivaraman. Does hierarchy exist within interprofessional teams, and how does it affect collaboration in healthcare?
Whom is this question addressed to?
Doesn't matter, sir. You tell.
Doesn't matter. Yeah.
Okay. Uh, see,
Sir, I'm
hierarchy.
Dr. Sivaraman.
Please, sir, go ahead.
I'm Dr. Sivaraman. I don't know. See, thing is, sometimes we collaborate with nurses, we collaborate with technicians, and as doctors, we feel that we should be on the top, or they also feel that we should command. And when we go for paramedical collaboration, like not paramedical, other Indian systems collaboration. So, like, how does, in your experience in your country, have you got that experience of hierarchy, or how is that hierarchy managed to establish collaboration? I'm sorry if I'm just asking spontaneously.
No, I will go ahead first.
Yes.
In your country means I am from India. So, so I don't know whether the question is for me, but let me talk about the hierarchy and strategies. Can you hear me?
So we had a slight echo from your side, but now it's clear.
Yeah, but tell me where hierarchy is not a problem. Leave aside interprofessional learning. Tell me where hierarchy was considered as something that has promoted, qualities, things. If you see, hierarchy has to be tackled at every level. Hierarchy, if it is happening for good, it's fine. But what you're talking about is hierarchy, which actually hampers, team functioning and health outcomes. Then it has to be dealt with. So hierarchical power structures have always led to tension, marginalization, and unresolved conflicts, right? Hierarchical power structures have always felt some team members feeling undervalued or excluded. So, rigid hierarchies, we all know that it perpetuates stereotypes. It inhibits the development of respectful, collaborative relationships across different healthcare professions. And we don't have to do a separate PhD for that. We all know about that. So, a punitive, power driven social climate will diminish team cognition. It's all about, you look at organizations that have flourished. These places have promoted shared leadership. They have encouraged rotating rules or concept that is not always filled by the same profession. Cultures that foster, I'm talking about educational and the cultures of organizational cultures that promote mutual respect will always organize training sessions where all team members' roles and contributions are discussed and appreciated equally. So you don't expect like a divine intervention and people changing overnight. Culture has to change. Professional cultures have to change. So use interdisciplinary meetings, interprofessional meetings, joint activities, regularly bring together participants from different professions to solve problems collectively and build understanding. Flatten the power gradients. You must clearly define roles and responsibilities while encouraging equal input during decision making. So if you look at a place like Manipal, when we started, same questions were raised. Is it going to work? But later, 10 years down the line, we find that the same clinicians are the people who are responsible for running the entire thing. They don't find it any difficult when it comes to sharing or resources or actually working with nurses or allied health. So what has this resulted into? An organizational culture that actually a reform that has happened, which has valued and integrated input from a range of professions, not just the traditionally dominant ones. So it is about two things that happen. One is organizational culture and the leadership and the will to change. And I think things will change if these things are in place. Maybe she has a different thought to share, Dr. Lakshmi.
No, I agree with you, Dr. Siraj, because this is more common. This hierarchical imbalances are more commonly observed in the developing countries. But when I went to US and Canada and I worked in the New Zealand also, there this interprofessional meetings and everything, and each one as respect each other's opinion, and it has been taken into consideration. And recently what happened, I was in Pondicherry and I was taking a break for 1 year and I met one of the professional colleague. Are you hearing me?
Yes,
Hello?
yes, ma'am.
Yeah, we are able to hear you, ma'am.
Very well, ma'am.
Yeah, I met one of the professional colleague who is working in the esteemed College of Nursing, and then she said, we go and sit in the meeting, and our words are not heard at all, and it's not taken into consideration, and it's automatically make them to shy away from the meeting, and they don't want to speak. This has been told recently, while I was in Pondicherry. So this is existing, and we need to break that barrier, and we have to work as team members. One thing what I want to highlight here, my African experience has taught me so many lessons. Nurses also, or nurses or doctors, has to be more understanding of each other's role, and we have to be more assertive and proactive in telling their thoughts and making sure that it's heard across the table and in a positive way. So we have to be more assertive, and then try to make changes in that. So that hierarchy, I'm really sorry to say that, and I observed even in India during my recent visit. So we need to really get over those things, please.
Moderator, I saw a few more questions related to practical implementations. Of course, I told the first thing relates to mindset, leadership, organizational culture. But at the same time, we also must address this head on. Otherwise, this will not. For example, there must be, somebody was asking where to start with, structured team-based simulation and case-based exercises. Where you can bring in at least one more profession, where people participate equally in patient care scenarios. And such cases must be chosen where there is obviously overlap of competencies coming from these different professions, so that it makes learners realize that it is also important to realize the most important roles played by other professions. So there is interprofessional team trainings that happen. Now these things have to be decided and implemented to the curriculum. Role clarification activities, as I told you, we conduct workshops and reflection sessions to improve understanding of each profession's scope of practice, what Dr. Lakshmi was mentioning. Now, this actually helps to reduce the stereotypes, misconceptions that often contribute to the hierarchy. Regular feedback sessions must be there, open communication and feedback, allowing team members to actually work together, share their concerns, celebrate successes together. And most importantly, this must be modeled by faculty. So mentorship and faculty becomes a very important aspect. Now, among the clinical community, there are enough number of clinicians who actually model collaborative behaviors, especially in hierarchically charged environments. We have seen people who are clear role models. Now, they are a part of this changing, long-standing culture. So, as I told you, these are the people who will lead the interprofessional learning and education that has to follow. I hope I've given some practical tips.
And there is one more question from Dr. Prashant. Where do we see interprofessional education being implemented with the rigid structure of our curriculum? Any best practices to start off and sustain itself?
And let me ask you, who decides that your curriculum is rigid or not? I mean, that's the first question. If you are, see, in the era of AI, in the era of most modern aspects that we introduce in the curriculum, who decides that your curriculum is rigid? It is we as teachers, right? Or people who it's just because somebody developed it and said that they never said it has to be within the rigid structures. They have people who have designed it, developed it, and given us to implement, have always encouraged to be as innovative and as transformative as possible. But the way we have implemented, I'm not blaming anyone, but we have actually made it more rigid. So when we say rigid structure of our curriculum, it actually points fingers at us. So now coming to your second part of your question, what are the best practices to start? When it comes to interprofessional education, we actually value teamwork and collaborative care. So if you look at one of the models that we have implemented here means I'm talking about Oman, it's longitudinally placed. So the first year of instruction, actually it's more generic team-based activities, and they are also sent as small groups into hospital where they interview a healthcare provider. It need not be a consultant, surgeon, physician. It ranges from physicians, lab techs, nurses, including the maintenance person who are a part of this hospital. And they interview and they find and they ask them what is their role in maintaining this environment and for supporting the healthcare outcomes. And then we ask them to find from their own teachers what, because they are in year one, what is their role as such, as when they have to, when they move through this medical curriculum and when they graduate, as say they do a little research and they do actually a sort of a mapping between these two. So if it was somebody who was in charge of sterilization unit, or it was a mechanic for that matter, forget about even the medical person, the student right from the beginning understands that it is an ecosystem that is maintained by collaborative endeavors, not just it runs by the whims and fancies of somebody who dictates terms. And so he or she develops an attitude for that collaborative acumen, right? So these are some of the exercises that you will have to deliberately plan, implement deliberately, not keeping somebody outside. It has to be completely inclusive. Equity is a very important aspect in this. And if you start doing such activities and slowly start incorporating it into, then for example, I'm not going to the details, in the year 4 they have a paper on lab medicine, laboratory medicine. Now, in lab medicine, they have an interprofessional learning session that happens along with the lab. You heard Kalambari saying, but here it is little more, pronounced, because they actually take up certain tests, and based on these things, not only on interpretation aspects, but how do actually communication. There we bring in communication and role clarification. Like that, it is actually put throughout the curriculum. And this did not happen overnight. Okay, it took us 4 years to slowly develop things, people, and then final years it actually comes into the patient safety aspects, where you have the scenarios which are very, very important, and it has to be tackled interprofessionally. Some are related to medication safety, some are related to other aspects. So you can longitudinally place it. Context is the king. What happens here need not happen in Pondicherry or need not happen in Chennai. You will have to decide based on your own resources, based on the situations, and based on the NMC guidelines. How do I really frame it? And there is where, Prashant, I will break the rigid structure of my curriculum. And NMC will not say that it has to be implemented in these rigid. No, they never say that. They have given you guidelines. You are actually responsible for its implementation with all the freedom that you have. But it has to be based on frameworks. It has to be based on best practices. It has to be based on prudent evidence. That's all.
Okay.
Thank you, sir.
There is one more question query from Dr. Bharat. I come from forensic integration included in interprofessional education. IP seems more than that. Why I'm asking, because just today I took my students to a law college. He wants to know whether interprofessional education is part of integration.
Could you please repeat? I didn't get that.
Sir, he
So
means.
Dr. Bharat wants to know whether integration is part of interprofessional education is part of integration.
The first part is clear for me. Taking your students to College of Law, understanding jurisprudence, and giving it an interprofessional dimension is an extremely important task. You have done a great thing. Only thing is, create a good framework, follow the principles of curriculum design, see what you are actually, see, basically, whatever you do, that is what I say. You must follow the principles of medical education or health professions education, or at least education. Whatever we do, it cannot actually be out of all these things. So if you're doing something and it has an intention based on interprofessional education, and if it fits into framework, and many people have done these aspects actually, legal aspects, it's more of an interprofessional concepts and jurisprudence. And the second part of it is integration interprofessional. Not really. Every interprofessional activity brings in integration, but every integration need not be interprofessional. For example, let me give you an example. In a class of anatomy, I do, for example, I'm doing on, let's say, breast. And then, of course, I bring in my surgical colleagues and they talk about, the possibilities of, the management of, or they talk about, let's say, breast carcinoma, and then aspects, lymph drainage and things like that. This is pure integration, a good level of integration, vertical integration, but you cannot call it interprofessional because it has its limitation. we know that we all belong to the same profession, you know. But if you have to take it to the next level of interprofessional, this thing, maybe in the first year only, you will also have social care workers. You may have somebody, if you really want to convert it into an interprofessional module, you may have patient experiences put along with that. You may have actually a campaign running parallel to that in the community, you know, breast care awareness. So you will have students from those professions. You will have a workshop done together with this. So it's not that simple as integration. But all interprofessional activities obviously are integration activities. All integration activities are not interprofessional. I hope I have answered your question.
Okay.
Sir, I think one more question was missed. The question was, somebody asked, how do we convince our administrators or higher ups that interprofessional education is very, very important and required?
This is a question in change management. This will need another workshop on change management we'll do. So this is not only related to interprofessional education. Anything that you actually attempt in higher education, specifically in health professions education, will be contested, will be actually, and that is what we need. We don't expect anyone to say, like it happened in, you know, with all due respect, like it happens in our place, we say, okay, fine, something has come, let's, no, it has to be with adequate deliberations. It has to be with debates. It has to be with all stakeholder consultations. So whatever applies to prudent change management strategies will also apply here. There is nothing that makes interprofessional education special in terms of addressing it. In fact, it is much easier. It is much easier than many of those things that we bring into health professions education, which have absolutely no evidence basis. Still, we have made it up because somebody has told it. But here is an approach that 50 to 60 years systematic inquiry not done by any independent agency. Agencies like WHO have clearly done this, and you have evidence to say that it brings graduates who are much competent in terms of, you know, collaborative care. It actually reduces the cost. It actually is the best solution for chronic ailments. In spite of that, still, if we have problem, we have to follow the same these things. You know, we have to see all those change management strategies. Nothing holds special for interprofessional education. If people have tried many things for implementing competency base, for implementing integration, the same thing follows here also. But I feel interprofessional education and collaborative practice has much more evidence than all these things in the scientific domain to tell that it works better.
Ma'am, any final words from your side? Dr. Rajeshwari, ma'am? Dr. Lakshmi Rajeshwaran, any final words from your side, ma'am?
But my sincere thing will be, of course, skepticism is good, absolutely, but um, try in a very small little way, following the tenets of interpersonal education. In fact, when we started this, um, when we also tried to include people who are out of health, we had a lot of resistance, especially from the classic IPE. They said that it must be confined to health professions education and its expert. But 10 years down the line, we see that people have changed. They also have included. That's why I'm very happy when Prashant said that, you know, they were, I think it was, I think Bharat or Prashant who said that we took them to the law college. But it must be with a framework, with a purpose, and if they understand, you know, such things, we may not really say that, you know, this is a form of interpersonal education, but at least you made an attempt to actually, you know, come out of the whatever you call the rigid, or but it happened, you know. So in the similar way, in our own domains, there is always a possibility of collaborating with other professions. But I told you the intention must be to enhance health outcomes. It is not like a research work that we do on changing. Of course, obviously it might change in due course. Somebody will find a specific valve or might have something modifications done with the catheter, and they're all interdisciplinary studies. But we are talking much more direct involvement with patients, and actually it enhances health outcomes in terms of reducing errors, in terms of enhancing quality. And in the Indian context, I would say it must bring down the cost, because it's not a fashion stuff. In this country, we need those interventions that bring down the bill of the common man. So then it becomes significant.
Okay. So that was really wonderful. So if there are no questions, I think let me consolidate. Is there any more question from the participant side? Okay, let me consolidate. Our esteemed speakers have highlighted how collaboration, shared learning, and teamwork are essential in preparing our 21st century learners, our 21st century healthcare professionals, so that they become future ready health professionals. Or I can say that Dr. Siraj, as he mentioned, that we really need to have interprofessional ready workforce to face the future healthcare needs of the society. So, no doubt, sir, interprofessionalism is the new order of learning, and the health profession educators need to embrace this interprofessional education and need to equip themselves in interprofessional learning as they are the because we are the custodians of the future physicians or the health professionals. So interprofessionalism has emerged as a powerful and educational movement. As I earlier mentioned, that it is already education movement in the Western countries, but in countries like India, it needs to take off fully. So I think we have to ensure that our learners receive holistic education. That means collaborative and practice ready training. So that means we can make sure that our learners become interprofessional ready workforce in the future. So the insights shared by our speakers have given us valuable perspectives in interprofessional education, and definitely I think these things will help us to enrich our existing curriculum and improve the quality of patient care in wherever settings we are working. So I thank the speakers, participants, and the medical organizing team for arranging this webinar, and special thanks to Dr. Abhishek for coordinating this event. As we continue JIPMER's Golden Jubilee celebration of NTTC, let us carry forward all these thoughts, whatever ideas generated in webinars like this, and work together to strengthen the interprofessional learning in our own institution. So attending a webinar is easy, but taking take-home message is very important. So you need to think how you are going to implement in your institution wherever you are working. So, and one more, a gentle reminder to all the participants, please register for the JIPMER Medicon. The website is jipmermedicon.com. The Medicon conference is scheduled from 1st to 4th April 2026. And please be part of this academic celebration. So we look forward to seeing you in the next webinar series. So now over to Dr. Abhishek for his concluding remarks. Before I take leave, I thank both the speakers for sharing their thoughts and insights. Thank you. Over to Abhishek.
Jaya, I have a question for you.
Just
Sorry.
this thing, Dr. Moderator, just one thing. I've just put my email ID in the chat. In case, as you said, because you said, implementation is the, so please, because we have made a lot of mistakes, we don't want you to do the same mistakes. You can always connect with us, in case, if you are implementing and if you need to share something, discuss with us, you're most welcome. I've just put my, that's what I'm saying. You don't have to make the same mistakes and waste time. We will be able to give you some guidance on that. Thank you, moderator, Dr. Zaya, and thank you others for inviting us.
One more question, Zaya. Sorry, you have spoken and I'm just interfering. I just wanted to know, I mean, from the nursing point of view, how much you involve the nurses in their your interprofessional education or in seminars and other things, or even in research? Do they come forward, or what is the existing situation? I wanted to know because I'm out of India for many years, so I just wanted to know, since JIPMER is an esteemed university, teaching institute. So just a few words, what is your observation on that?
Ma'am, honestly speaking, my personal experience in JIPMER is that there is no explicit involvement of nurses in medical education. But knowingly, but informally, they are involved in many aspects. That's what I can say. But because the curriculum is like that, already the curriculum is overloaded. Even it is not enough for the current faculty to deal with the curriculum because shortage of time, shortage of resource, more number of students. So now that is not straightforwardly possible to involve the nurses. But still, wherever it is possible in an informal way, we include nurses. Say for example, one good example that is taking place in our own department, medical education department. Whenever BLS program is organized, all stakeholders are involved. So without the nursing staff, we cannot. Sometimes they come as simulated patients. Sometimes they organize programs. Now recently they organized a soft skills program for the residents, and they are also involved in Tamil language learning program. So these are all some of the informal ways where we rope in the nursing faculty. But as Dr. Siraj mentioned, and as you mentioned in your talk, there is no formal integration of this nursing faculty into the medical thing. Otherwise, I don't know. I'm not a clinician, but I don't know what's happening in the ward. Maybe Dr. Abhishek or Dr. Kadambari can share their experience, their thoughts regarding this.
Oh,
Kadambari madam
thank
has
you.
raised her arm to speak.
Yeah, I just wanted to add one in a response to Dr. Lakshmi's query. We are involved as clinicians in student nurses research projects. And in fact, the nursing research monitoring committee is chaired by one of us clinicians. And we have people from the clinical and other supporting departments, the paraclinical departments, who monitor the research which nursing students do. But unfortunately, there isn't a reciprocal involvement of nurse faculty in our research committees, as far as I know. But as I said, informal learning is a very common thing that happens. We do informally see what nurses are doing in the ward when they come for their ward postings, but it's not a formal exchange of. And we used to take some classes for nurse students earlier, but now the College of Nursing has become self-sufficient. So they do their own teaching. Otherwise, I have taken classes in surgery for BSc and MSc students several years ago.
Madam, let
Thank
me
you.
share our experience.
Mhm.
I head the Department of Transfusion Medicine here. So transfusion medicine gives you a unique opportunity where we have the nursing staff, the laboratory staff, the counselors, um, the motivators and all these people. And in our department, we regularly, at least once a week, make it a point there is a one common session where all these people are involved, whether it is discussing about the monthly statistics or the KPIs and all that. So we do it regularly and we involve all the cadres, everybody in the department for this, and that that has definitely improved lot of things and made everybody what you say feel involved and empowered, and it has definitely given much better results to us.
Oh, thank you. Thank you, Dr. Abhishek. Next time when I come to Pondicherry, then I'll make a visit to your department and then you can also assist me to understand in a better way. Thank you so much.
Thank you. So with that, I'll thank everybody, including right from the conception of this thought of having webinars, Kadambari Madam, the Department of Medical Education, all the people working behind the scene, the technical staff, and of course, the speakers of today, sir has already mentioned and thanked them. I would also thank Dr. Jayaprakash Rajan, who was the moderator as well as holding the helm of this. And please be watching for the subsequent webinars in a week's time and make use of these sessions. That's it from Jipmer. Thank you. Good night and whatever
Thank you, my
day it is. Thank you all.
Thank you.